My name's Nick Screeton. I'm president of the BIR, and as has been alluded to, we're here to award one of the BIR's most prestigious awards, which is the Medal for Outstanding International Achievement. It's a prestigious prize which recognises transformative and outstanding achievements in radiology, radiation oncology, and its associated science globally. It's quite a recent award, started in 2020, awarded every other year since then. Nominees have all made major contributions to their subject over extended periods at international level, which has materially advanced medical applications in radiation-related sciences. And it's an honour today to announce the winner of that award, who is Professor Marco Durante, for the 2024 medal. Let me give you some background. He's Department Director at GSI Helmholtz Center for Heavy Ion Research. He's widely recognized for his major contributions to charged particle research, principally in relation to cancer treatment and space radiation protection. He's been head of the radiophysics group at GSI since 2007, with principal research interests including molecular radiobiology, clinical radiobiology, radiobiological modeling, treatment plan validation, medical physics, and space radiation physics, which is all way beyond my comprehension, but sounds very diverse and very impressive. He's also had sort of global impact, having held positions in the NASA Johnson Space Center in the USA, National Institute of Radiological Sciences in Japan, and the European Space Agency. Practical realizations of potential benefits of using protons and other charged particles for cancer treatments requires an understanding both of biology and of radiation physics. And those are areas which he clearly has very extensive understanding in order to ensure optimal utilization of these techniques. Professor Durante has been at the forefront of his areas of interest for many, many years, and is a very worthy recipient of this BIR medal. And he sits there looking very relaxed and humble. But with that, let me invite you to the stage, please, to receive your medal.
I mean, yes, I think I would like to say a couple of words. I mean, because it's a really great honor for me, a pleasure and an honor to receive this award. As you have heard from my CV, I traveled a lot in the world. I studied in the US, then in Japan, now I'm in Germany. I'm originally from Italy. But my first travel abroad was to London when I was 14 years old. And as most teenagers in continental Europe at that time, the dream was to come to London. Because for us, UK was the most interesting country in Europe, the place where you really want to go, you want to see, you want to learn the culture, you want to understand the people. Not so much the food, but all the other things, yes. So for me, London and UK are always in my heart, where really my first travel to UK was when I realized that I wanted to live in the world. And I felt that UK was so much part of my culture and of the European culture. I'm sorry to say that. I'm still shocked by the Brexit because I always felt that UK is part of Europe and we are part of UK. So for me, this is a very great honor. I also understood that the Institute of Radiology in the UK is the first Institute of Radiology in the world, historically. And this I told to my German friends, and they said, that's not possible, it must be Germany. I said, no, sorry, they were better organized. So even if X-rays come from Germany, eventually this was the first one, so this gives me even more honor and pleasure to receive this very important award. Thank you very much, really, for this. Thank you. So thank you very much. So now we go to the serious part. So we'll talk about my expertise, which is particle therapy, of course, which is something which is also very well known in the UK. There are two NHS center, one here, I think it's pretty close. I mean, this UCL center and one in Manchester. Yes, it works fine. So the principle of particle therapy, I think you all know. Essentially, it's all in this picture that we always show to get funding for particle therapy, because you see the blue curve is the depth dose distribution for X-rays, and red or green curves are the depth dose distribution for particles, protons or carbon ions, that are the two particles currently used in clinics. In Heidelberg, they are treating a few patients with helium-2. And when I was very young in Berkeley, they treated many patients with helium and also heavier ions. But if you look at this picture, it's immediate to think and say, okay, that's much better for radiotherapy, because of course, if you have a deep tumor, the particles are automatically conformal. They will give you a low dose to normal tissue and high dose to the tumor. But in addition, you have biological advantages that stems from the fact that when you go in the area of the Bragg peak, then the LET goes up and they become more effective. Let's say a little bit like in the entrance region where the normal tissue is, they are more similar to X-rays. But in the Bragg peak, they become more similar to alpha particles that are well known to be extremely effective. This is not completely true for protons that are always kind of low LET, but becomes more and more true when you move to heavier ions like carbon. In any case, if you look at the physics, this is the main advantage of particle therapy. You see that essentially for all sides, you have CNS, head and neck, lung, abdomen, pelvis. If you treat the patients with protons, this is protons versus X-rays, you will spare a lot of normal tissue. That's the main point. Thanks to the Bragg peak, you can spare a lot of normal tissue. And if you look at the first picture here, this is CNS. So that's a typical case for pediatric patients that are now in the UK, are treated mostly here and in Manchester with protons. And you see how much brain you can spare if you use protons instead of photons. And that's, by the way, one of the reasons why it's so difficult to make randomized clinical trial with protons. Because, of course, if you show this picture to the mother of a 7-year-old baby and you say, we're going to randomize your baby between this treatment and this treatment, she will not be very happy, because they say, no, I want the best for my child. I want this one. I don't want this one. That's the problem of the ethical issue in randomized clinical trials. Now, whether or not this physics advantages translates into a clinical advantage is a matter of debate, of course. But I will show you some data trying to convince that this is true, this really happens. Let's say this useless blue dose that you see in many of the X-ray treated patients makes only harm, gives you no benefit. But before that, let's go back to biology. So what is the difference between particles and photons? You see, these are nice pictures, live cell imaging of DNA repair proteins in cells, human cells irradiated with X-rays. For those that are not radiobiologists, and we have someone here, I just want to explain it a little bit better. This is the nucleus of the human cell. And this foci that you see, these green spots that you see, is the 53BP1 protein that rush to the site of DNA double-strand break, trying to repair it. And that's another protein that does the same thing. So you break the DNA, the protein rush, the proteins are fluorescent because they are GFP tagged, and so you can see them live. And you see that the distribution of the damage is fairly uniform. It's a little bit everywhere in the nucleus. What happens if you use particles, if you use carbon? Well, if you use carbon, the picture will look much more like that. You see now, this is the time here, this move is only slightly accelerated. The response of the cells to the radiation insult is extremely fast. And you see two particles here going through the nucleus. One is here and one is here. So that's the problem of particle radiobiology. You can see here there is another example in mouse. These are mouse fibroblasts here. What is the difference between this picture and the picture I've shown you before? How the biological response change when the damage is so strongly correlated in streaks rather than being randomly distributed in the nucleus. I said, this is a zoom, just to show you. This block here is heterochromatin for the biologist, and you see that the repair in the heterochromatic block is slower than the euchromatin. In fact, the chromatin is too compact here, and the cell has to push the damage outside of it to get it repaired. Okay, so I was telling you there are advantages in the physics. Let's go back to the physics for a second. One advantage is that if you spare a lot of normal tissue, you spare a lot of lymphocytes. And lymphocytes are very useful cells, especially these days that we all know that oncology, the future of oncology is immunology, is immunotherapy. Now, this is a nice review from the Roissy Institute in France, where they show that essentially for all tumors, lymphopenia, so the loss of lymphocytes, is a negative prognostic factor. If you get lymphopenia, you will have a worse outcome than if you get no lymphopenia. And actually, I did an experiment many years ago. That's an experiment that dates back 2000. I did it in Japan, comparing patients irradiated with X-rays and carbon ions. So we were taking the blood from the patient at different doses, so different fractions if you want, and we were looking at the aberrations in the lymphocytes. And we were expecting to see more with carbon ions, because if you do the experiment in vitro, carbon ions are very effective in inducing aberrations. But we did not. We found many more aberrations with X-rays than carbon ions. And this is physics, it's not biology. Because you spare so much normal tissue, you spare many lymphocytes. And so if you look at the fraction of aberrant cells, you find less with carbon ions than with X-rays. This paper has a funny story. I always tell this one. Was published in 2000. Up to 2011, 2012, got maybe a dozen of citations, maybe even less. Then from 2012 to now, got 150 citations, 200 citations. Why? Because then immunotherapy came. It was the breakthrough of immunotherapy. And then people realized, oh, lymphocytes are very important. We need lymphocytes if we want an immune response. And then these results that were completely ghosted for many years, they suddenly became very important. Now, every clinical trial, this is just, I don't want you to go in details, but just to show you that essentially every randomized or comparative clinical trial, protons versus X-rays or carbon ions versus X-rays, include lymphopenia as an endpoint. Because most of them show that there is an advantage in using protons in comparison to carbon ions. So that's maybe a message for the young people in the room. If you publish a paper and nobody cares about that paper, don't get too disappointed, because maybe in 10 years suddenly it becomes very popular. It's you never know. It's called serendipity in science, and it's an interesting effect. So everything looks good, and in fact, the number of proton therapy centers that are this complicated object, you see, this is a proton therapy, this is a cyclotron, and this is a gantry that rotates around the patient, is actually very rapidly increasing. There is a clear exponential growth, you see, as a function of the number of years. You find these numbers on the web page of PTCOG, and of course, as president of PTCOG, it's my duty to invite all of you to visit the webpage and to register. It's completely free, so you don't have to pay anything, and you will be part of the family, let's say. But as president of PTCOG, I have to say that not everything looks so wonderful. If you open the newspapers, you find a lot of controversy, especially in the UK. I mean, not only in the UK, but especially in the UK. People say, okay, this therapy looks wonderful, but it's very expensive. And it's true, it's much more expensive than X-rays. And we have no level 1 evidence. So we don't have double-blind, randomized phase 3 clinical trials proving that particles are better than photons. So we spend much more money for something which is not really proven. In the pharmaceutical world, this will be not acceptable. No, when you have a new pill, you have to do a randomized clinical trial. To be completely honest, in the radiation therapy world, 90% of the innovation goes in the clinics without randomized clinical trial. When SBRT started, when CyberKnife started, there was no randomized clinical trial, but they did it anyway. But this is clear, So do we have now at least some randomized clinical trial to show the superiority of particles in compared to photons? One example that I like is based on a classical application of protons. It's the craniospinal irradiation for medulloblastoma. It's typical treatment for pediatric tumors. It's done in the UK now, I think both at UCL and Christie. And you see the advantage. The problem here is that you have to irradiate the head and the spine. So if you do it with photons, you essentially make a sort of whole body irradiation. But if you do it with protons, protons stop. And so you can nicely spare so many organs here. Now, a few years ago at the Sloan Kettering in New York, they had the idea, I say, okay, why don't we use it for patients with leptomeningeal metastasis? That's a bad disease. It's very bad. When the metastasis spread in the cerebral spine fluid, the prognosis becomes terrible, and the lifespan is only every few weeks, not even months. So they say sometimes people irradiate with X-rays to try to prolong the life, but they say let's randomize the patient and try craniospinal irradiation with protons. And here the results are very clear. You see in red, this is the progression-free survival, and this is the overall survival. In red is protons, in blue is X-rays. Of course, as you see, you get an improvement, significant improvement when you use protons in comparison to X-rays. So that's an example, let's say, of a positive randomized clinical trial. For a specific endpoint, I agree, but is an example that what we physicists can predict, let's say, based on the dose distribution actually corresponds to a clinical result. The other trial I want to describe is still not published. I hope will come out on New England Journal of Medicine soon. It's an MD Anderson trial for oropharyngeal carcinoma, which is a common head and neck tumor. In the US, that's mostly HPV positive. In Europe, you have many more HPV negative that has a worse prognosis. That's a different story, but it's an interesting story, in my opinion. So what they did, they randomized patient protons versus IMRT, and you see the primary endpoint was toxicity, and you see that gastrostomy tubes are radically reduced when you use protons. So the patient don't need to be fed with the tube, which is a clear sign that the toxicity is reduced. With some surprise, I have to say, they even found a better survival, which was not predicted in the planning of the trial because the dose to the tumor was the same. So you say, same dose, same survival. there is a discussion on why they got a better survival. My personal opinion is that they spared more lymphocytes, so they had a better immune response, and that's why they get a better survival too, which was not expected. I also like very much this plot because I told you particle therapy is expensive, is very expensive, true. But this is the fraction of patients that go back to work. And you see, for patients in therapy, in proton therapy, it's almost 80%. But in patients that go X-rays, it's about 50%. That's not only benefit of the patients, but is also for the economy. I mean, these patients are going back to work. So when we count the cost of particle therapy, we have to include the cost of a patient going back to the hospital because still has toxicity. We have to include the cost for the society of having to pay a pension to a person that cannot work anymore. These are all factors that are very important, I think. So in conclusion of this phase, let's say, what is the fraction of patients that benefit from particle therapy? Actually, in the UK, there have been many studies that I like very much in this topic. This is a paper of some years ago that summarized 3 different studies. They were asking different people how many, mostly medical doctors, but also medical physicists, how many patients really benefit. And you see that the majority answered somewhere between 10% and 20%. We have something in between 10% and 20% of the patients that really benefit. Then there are those that are a little bit more negative, you see. And you see someone said 100%, but I have to admit that I was interviewed too, so I'm afraid this is me here. So a little bit bias in this paper because you know, from my point of view, it's always beneficial. I mean, sometimes you see the benefit because the conventional radiotherapy is very toxic. Sometimes you don't see the benefit because conventional radiotherapy is already good enough, but in principle it's always beneficial. But in any case, you know, 20% is already a very large number. A very large number. You will need many more than 2 proton therapy centers to cover 20% of the UK patients. Okay, now, a little bit now about the future, let's say, because this is called future. So what can we do better? I think we have to do 3 things for particle therapy now. If we want to democratize particle therapy, we have to do it cheaper. There is nothing to do. We have to do it faster, and we have to do it more conformal. And I will explain you why. On cheaper, what does it mean cheaper? I mean, these are the cost in €1,000,000, but it's close to the pounds. And you see how the cost goes up with the footprint. So you can imagine that the most expensive part is the accelerator, but the real expensive part is the footprint. You have to build large buildings with huge walls for radioprotection purpose. So the biggest are the machine, the more expensive they become. You see, you go from for a Linac for X-rays, you only have 50 square meters and 5 millions, but then for protons you already go to 30 millions and 500 square meters. And if you want Heidelberg, that is multi-ion, protons, helium, oxygen, carbon, whatever you want, gantry for heavy ions, you go to 200 millions with 5,000 square meters. So we have to make it more compact. There are many projects here. This one is from CERN that they're planning to do a much more compact triangular synchrotron that for people expert in accelerators is very interesting. And of course, the most advanced are the Japanese, as usual. They are now planning to go down to these sides, which is only 20 meters by 10 meters, with an injector, which is a laser-driven accelerator, actually. They want to use a laser-driven accelerator as injector of the particles. But another point is that there is a large fraction of the space which is not taken by the accelerator, is taken by the gantry. The gantry for protons and especially for heavy ions is huge, massive, and you have to rotate it. What about if instead of rotating the gantry, instead of rotating the beam, we rotate the patient? We can put the patient in vertical position, and we can irradiate the patient in vertical position and rotating the patient. This is definitely not a new idea. Actually, it's a very old idea. The first patients in radiotherapy were treated in vertical position, not in horizontal position. But the game changer here is the vertical CT. So now you can do the planning in vertical position. And if you do the planning in vertical position, then you can be sure that the organs are not moving, and you can do your irradiation in vertical position. This will definitely save a lot of money. Now there is a large Marie Curie project called Uplift to study the irradiation in vertical position, where also UK centers are involved, and I hope it will be successful. There's also already a couple of companies that are selling solutions in vertical position. This is an Italian company that sells a linear proton accelerator with one irradiation in vertical position, and this is PQR. It's an Israeli company that sells a synchrotron. This is a synchrotron, but a very small synchrotron. It's without quadrupoles, it's only dipoles, and then goes into irradiation on a chair. This machine of PQR fits a normal volt of photons. So in principle, they say, if you want to replace your Electa or Varian Linac, we can fit this machine in your volt. And this is definitely interesting. Faster, here I really don't want to spend too much time because we will have a lecture later on Flash. And Flash now is a sort of boom of hype. I think everybody heard of it. This means that to irradiate the patients in less of a second, which of course is a big advantage for medical physics, especially for treatment of moving organs, for example. But recently it came out that was also an advantage for biology, because you spare the normal tissue while the tumor control remains the same. We at GSI, I mean, as I have to say, we did it with carbon ions. We have a beamline where we did it. These are mice here, and there is a detector behind. So if you look carefully, I hope the movie will work if I click. Yes, it does work. You will see, at a certain point, you will see the beam. Boom, you saw it. This was 18 gray in 200 milliseconds to the chest of the mouse. We were looking at the induction of lung fibrosis. So you see, we were able to give a huge dose, 18 gray, in 200 milliseconds, without inducing a strong toxicity of the mouse, because this was done in such a short time. But I leave this to the next talk on Flash. Finally, conformal. So we are very proud of how conformal we are. Look, it's wonderful. We do pencil beam scanning. We can scan the tumor layer by layer. It's absolutely perfect. Our conformality is absolutely amazing. No doubt about that. So much no doubt that you see, if you treat mesothelioma, this is a mesothelioma, so this is a famous tumor induced by asbestos mostly. You have to treat the full lung, and you see protons stop, so you can treat the ipsilateral lung, giving essentially zero dose to the contralateral lung. The problem is that protons stop, but we don't know exactly where they stop. And because it's a Bragg peak, if you make a mistake, this is what can happen. You know, if you don't calculate the range right, this is what is going to happen. It's much more critical for protons than for photons. So you make a disaster here. And that's why we are forced to make large margins. You know, this is what we could do for this treatment plan with protons. You see that the spinal cord is completely out, the esophagus gets a very low dose, but then we have to make bigger margins because we don't know exactly where is the beam. And then we have a much worse treatment. We spoil our wonderful conformality. You can think, okay, but if you put the margin is not so much in comparison to a big tumor. There was a paper from a Belgian group a few years ago in Nature they made an example that I like very much. If you imagine that the tumor is an orange and the margin is the skin of the orange, just peel your orange, put the skin next to the orange, and you will find out that the volume is almost the same. So adding a margin means that you are irradiating a lot of normal tissue, really a lot. That's because, the spherical geometry, let's say. So what can we do with that? There are many techniques, I have to say, under study. Also in the UK, there are many studies on proton radiography. For example, at GSI, we have this more powerful tools. We are trying to use radioactive ion beams. Why radioactive ion beams? Because if you use a beam, which is a beta plus emitter, just like those that you inject to make a PET, then you can see the beam while you shoot the beam in the patient. And you can get very high signal-to-noise ratio. You see, this is carbon-12 dose, and this is the PET signal from carbon-12. This is the fragments of carbon-12 that you see. But if you use carbon-11, you have a very strong and clear signal. So you will be able to see the beam while you are irradiating the patient and to move it correspondingly. We did the experiment recently. This is still not published in a mouse. You see here, this is the PET detector. This is the mouse. The mouse had the tumor implanted in the neck, very close to the spinal cord. So our challenge was to give a very high dose, 20 gray, to the tumor, one shot, without paralyzing the mouse. So we had to make sure that we were not hitting the spinal cord, thus paralyzing the mouse. And that's how it looks like. You see, this is a sagittal view and a transversal view. The time is up. And you see that gradually, you see the image of the beta plus carbon coming up. And you see that we could check that we were actually destroying the tumor without invading the spinal cord while we were irradiating. And this is currently, the paper is now under revision, but in Nature Physics, but I hope we will be able to publish it soon. You see it, I just want to show it one more time because I like it very much. It's a very, very precise technique. Okay, so in conclusion, particle therapy is rapidly growing. I think we all agree on that. And also we have more and more evidence, clinical evidence, supporting the physics and radiobiological rationale. However, only about 1% of radiotherapy patients are treated with particles these days. So we have to help with physics, technology, with research, essentially in three ways: cheaper machines, more conformal, and faster. So flash radiotherapy and improved workflow. And with this, I'd like to thank you on behalf of my group at GSI, which is, as you see, a very big group. We are about 50% physicists, 50% biology, 16 different nationalities, very international. If there is any young person interested to come, we are always very happy to take brilliant young people, a lot of young people. The average age is very low, and we save the institute with the gender balance because we have more female than males, but because it's a nuclear physics institute, normally it's 90% males and 10% females, but in our department we have more women. And then a special thanks to the British Institute of Radiology again for this award, and I also have to thank, of course, the funding agencies that support my work at GSI. Thank you very much, and I'll be happy to take any questions. Thank you.
That was an amazing talk. Thank you very much, Marco. Do we have questions? Stunned silence.
Yeah. So you talked a lot about the physics and the targeting, but since we're in the radiobiology row, in terms of the relative biological effectiveness, so the differences in biology in these beams, there's a lot of uncertainty there. Yeah. Do you think that's limiting the benefit here, or can we get a good enough guess for these RBEs and still get benefit from particle therapy?
Yeah, This is always interesting because, of course, RBE is a benefit because the peak to plateau ratio goes up when you have high RBE. So the real issue that I see here is to understand the RBE of the normal tissue. Most of the RBE studies are done in tumors. I don't care so much about the RBE in tumor. I care very much about the RBE in the normal tissue because that will be my limiting factor. Once I know my limiting factor, the RBE will only be an advantage. And moreover, when you move to high LET, it's not only a matter of RBE, but also of oxygen enhancement ratio. So you get a reduced oxygen enhancement ratio, which is particularly useful for hypoxic tumors like glioblastoma or this kind of nasty and difficult to treat tumors.
Do you have any more questions?
Yeah, another biology question, Marco, but yes, excellent talk. So I wonder if you could briefly comment about other particles. You mentioned helium, potentially oxygen. What's needed to kind of move them more towards the clinic and when they're going to be particularly useful? Yeah.
So unfortunately, let's say if you ask what is needed, that's about regulations. Regulations are, of course, the terror. I was with an American friends last week, and they said, yeah, these days Americans made innovation, Chinese copy, and European regulate. I'm afraid he was right. But from my point of view, helium is very nice for physicists because you get a much better physics than with protons. You get far less lateral scattering. You can do hypofractionation much better because with the penumbra of the protons, hypofractionation can be a bit risky with protons, but is much better with helium. Oxygen is much more interesting for the biologists because then you go into the high LET and then you want to see what happens to the oxygen enhancement ratio, but also to the immune response. Also, the immune response can be changed at high LET, and this is a field which is still largely unexplored. While with helium, I don't expect any significant change in radiobiology in comparison to protons.
I think we better move on now, but thank
There's one last
one
question,
question,
maybe?
sorry, carry
I
on.
will be fast.
I'll sneak in with a very quick question. Marco, that was
Yeah.
a great presentation. I liked the when you were bringing in the example of a much more compact laser-driven accelerator. How close is that to being clinical, or is it clinical?
Not very close. I'm sorry. I mean, I'm saying something which can be unpopular here because I know there is a lot of research, but unfortunately, we are not very close. The problem, of course, as you know, is the energy spectrum is ugly for therapy because it goes down and you need the high energy part. And the reproducibility shot by shot is still not so good. So I think we are not close. But I think it's a very interesting research topic. So, research has to be pursued in these things because, you see, radioactive ion beams are not going in the clinics tomorrow. I'm absolutely sure. I'm very happy of my experiment, but I know that this is not going into clinics tomorrow, not next year. Will take maybe 10 years, maybe 20 years. But someone has to do this research, and same for laser. Someone has to do this research without overselling. That's the point. So, because in Germany there was a person a few years ago that was telling everybody that he was going to put the tabletop laser in every hospital in 2 years, so all my work was useless. And we don't see these tabletop lasers in every hospital, But it's a very interesting research because you see, and the Japanese are also working a lot on that. But don't expect to see it tomorrow.
I'm sure we could keep you up all day here, Marco. Well, we'll have to move on now, but I'm sure we'll catch you later. But thank you very much.